Checking. Hello. Welcome, friends. Hello. Checking. Checking. Hello. Yes, it's okay. So I'm watching your chat in the other system. So we are going to start Sensational 6 series. I'm going to discuss 6 questions from 8 important chapters in this discussion. And very important, I want you to ask more doubts because this is more of a doubt clearing session. Near exams, you'll have so many controversies, so many doubts. That will be more helpful in this session because I'm seeing your chat in another system. Welcome, Mr. Khan. Welcome, Mid Corner SS. All of you, welcome. So we are going to start the session in just 2 more minutes. I'm waiting for the students to join. Just 2 more minutes, we'll be starting back. So hope my audio, video, everything is fine for you. Katuraju Suresh, I hope my audio is good for you because I'm doing in another software on Zoom and I'm relaying it on YouTube. So any disturbance in the audio or video, please tell me, okay? Any disturbance in the audio or video, please tell me. Hi, Vijay, welcome. Okay. So we'll start the session now. Discussing the previous year question is more important in any exam, whether it may be a INI set or NEET PG or FMG. The reason, basic reason why we should be very thorough with the previous year question is, you should understand, those who work very hard will not be the succeeders. The success goes to people who work smart. So smart work yields better result than hard work. So how to work smart? Please remember, previous year question, why all the faculties are stressing because of one important reason. One of the important reason is question papers are set by the same set of examiners. The examiners will not change. They will be always the same set of examiners will be setting for surgery or medicine or OBG. So therefore, you will get same set of questions again in the exam. Even there may be not same set of questions, but the same concepts will be asked. The reason is because some examiners will have some favorite areas. They will repeatedly ask those favorite areas. That is why we get previous year question repeatedly. So therefore, I am going to discuss in these 8 episodes, I'm going to discuss the important chapters covering entire surgery, all the essential previous year questions. I'm not going to discuss all the basic questions. I'm going to discuss certain questions which you might have controversy, which are highly essential for last minute revision. Okay, I won't waste most of your time. This will be a dinner session. Just have your dinner, idli, dosa, chapati, naan, something, whatever you're eating. Just have this system on your side and you just see the videos. Don't write notes, anything, because this is not the time to write notes and keep preparing with the notes. So just listen to the class. My video may not be straight, might be lying down. So don't worry about me. Just see the one which I'm going to discuss with you. Okay. So we are discussing the first episode on trauma. Okay, this is the first topic. So we are going to plan 8 episodes totally. So this is the first episode we are going to discuss today, that is on trauma. Hope you are seeing my screen there well. Yes. Thank you, Katuraj Suresh. So I'm going to start the discussion now. So the first question from this, just I'm going to discuss 6 questions. I'm not going to waste most of your time. If you are knowing the answers already and you have already very clear with the concepts, I'm very happy. Okay. So see the question, first question from last year, NEET PG 2022. A young male shown in the image sustained a stab injury on the anterolateral aspect of the abdomen, and he is presenting with BP of 120/80, pulse rate of 80, Next step in the management will be, so let me see how many of you are answering this correctly, because this is a classical image-based question. You can see the abdomen is having some contents are protruding out following a penetrating trauma. Wound cleaning and wait and watch was done. Immediate laparotomy will be done. CT abdomen will be done. Need further investigation. The question is very clear. You should always see this word. What is next or what is best? So what is next in this question is the answer here. So next is what? So next answer here is, yes, anybody is correct. Very good, Ram Krishna, that is correct. Ayush correct. Tamil Nadu bit, that is absolutely correct. It is immediate laparotomy. Sir, many other faculties are discussing like CT abdomen because pulse rate and BP are normal. This is what many students told when we were discussing this question. Yes, even now Priyanka is answering as 6. C, she is answering as C. This is a very important, interesting question. See, please remember the questions are not taken just like that from any book. It is taken from certain standard books like Bailey and Love and Sabiston. This is a straightforward, direct question from Sabiston based on this table. If you see the table, you'll get confused. Let me discuss this table by my own method. So now let me discuss. So don't worry about my image will be little not clear. Just see the screen alone because I'm using an iPad. It will not be clear. So I want to discuss 2 important protocols. Blunt trauma protocol. So please see, very simple protocol. Definitely one of the question will come. In a blunt trauma, the question is, a patient comes to you with a blunt trauma. What will you do next? The question is, what will you do next? I will do, don't get confused. It is always A, B, C, D, E. Airway, breathing, circulation, disability, exposure. This should not be changed. Whatever the case, this should not be changed. Airway should be the first, breathing, circulation, disability, exposure. This should be followed by what? This should be immediately followed by E fast. So no confusion, very simple, straightforward protocol. You should do E fast. If E fast is positive, what should I do? If E fast is positive, I should see whether the patient is stable or unstable. Unstable in the sense, the BP is less, systolic BP less than 90 millimeters mercury, pulse rate given as more than 100 per minute or 110 per minute, like that. They are given very unstable contents are given. Such cases, what should I do next? Very simple. Stable cases, you should do CECT abdomen. Unstable cases, shift them for laparotomy. That's all. Simple protocol for blunt trauma abdomen. So blunt trauma protocol, you should never get confused. So I'm telling you, don't get confused with the protocols. Protocols will be very simplified questions. If you are going to read it in a simplified way, definitely you'll answer all the questions. So stable patient should undergo CT abdomen. Unstable patients must undergo laparotomy. Simple. Okay. This is first thing. So no confusion in this. Now I'm going to tell you about the penetrating trauma protocol. Penetrating trauma protocol. So in a penetrating trauma protocol, what comes next? What will be the next? Next will be same A, B, C, D, E. So this is a part of primary survey in any trauma: airway, breathing, circulation, disability, exposure. There is no change in that order. Then in penetrating trauma, does E fast have a role? Very important question. Very important. Please don't forget, E fast has no role in penetrating trauma. In a patient who got a knife injury in the abdomen, there is no role of penetrating E fast. E fast is not useful for penetrating trauma. Please remember this very important golden rule. E fast will not be coming under penetrating trauma at all. Then what should I do next, sir? In a penetrating trauma, patient comes to you, you should see for 3 important findings. Number 1, whether the patient is having peritonitis, because a knife has entered the abdomen, it can cause guarding and rigidity. Yes, peritonitis is present. Patient is unstable, hemodynamically unstable. Yes, BP very low, pulse rate is increased, so very unstable. Patient is having bowel or any contents like omentum protruding out, coming out of the knife injury through the place where the knife has come, has entered, contents are protruding out. This is next important thing you should not forget. This is very important. Next thing you should not forget. What is happening, you should not forget in this thing. Okay. So peritonitis, unstable patient, bowel plus omentum protruding out. In these cases, what are you going to do next? In a patient who is having peritonitis, protruding bowel, don't ever think of anything else. Directly shift him for laparotomy. That's the answer for this question. This is a simple question that was asked. If the controversy usually happens for INI set exams, if peritonitis is not present, patient is stable, bowel and omentum are not protruding, what should I do? That is a very important next thing. So what will you do next? If everything is absent, no peritonitis, patient is stable, bowel and omentum are not coming out, what should I do next? Local exploration of the wound. Okay, local exploration of the wound. This will be the next. What else will be done? We can also do CECT abdomen. But better answer will be local exploration should be the next best step. In local exploration, please see, in many times what happens, the knife which was put, that patients would will be having this much layer of fat. Knife would have not even entered half of the fat. It will be only a simple skin injury. Okay, local exploration, look for peritoneal breach. Peritoneal breach should be noted. If peritoneal breach is present, then we will go for CT abdomen. This is an ideal protocol from super specialty books. But Sabiston doesn't say this protocol, but Sabiston says what should be next in a stable patient will be local exploration or CT abdomen will be done only for stable patients. But in this patient, he is stable. But what happened in your case? Bowel is coming out. So go for laparotomy. So then how long will I keep the patient? In a patient for whom the bowel is protruding out, or when there is a peritoneal breach, what will I do? I will do a CT abdomen and keep the patient in observation for 24 hours. Don't discharge him. Keep him, measure him hemoglobin, measure him BP, pulse rate, and keep him for 24 hours. If 24 hours, nothing happens, discharge the patient. If nothing happens for 24 hours, you can discharge the patient. This is a very important, simple protocol for your exam. So this is a simple question on penetrating trauma of abdomen. Do you have any doubt in this question? Please tell me. Because I want to just give a clear-cut answer based on the protocols. Abdominal stab wound, patient having shock, peritonitis, evisceration, air under diaphragm, hemodynamic instability. Directly you can go for simple line they have asked. They didn't even go into the deeper lines in Sabiston. They just asked a question, abdominal stab wound, bowel is protruding out, go for laparotomy. Okay, if there is nothing is present, you can go for where are the injuries, what all things, we can go for the other things. Okay, simple question from first question from the sensational 6 questions. This is very clear question. Okay, so I'm just going to discuss some 6 questions from each system, which are highly sensational topics, which can be asked again. And it is nearly question paper leak questions only. All these are leaking questions. Most of these questions will be repeated ditto in national board exams, especially NEET PG and FMG. These areas are high yield areas. Okay, so you should be thorough with these areas. 30 years old, if you're already, I'm telling you again, if you're already knowing all these 6 questions absolutely correct, I'm sure you'll get a rank. If you're already knowing all these 6 questions correct, means definitely you're going to get a top rank within 5,000, you'll definitely get. Okay, the second question. 30 years old patient presented to casualty following a motorbike accident. He has bruises over the chest. His pulse rate is 120 per minute, BP 90/60, respiratory rate 40 per minute. Chest X-ray was performed and shown below. What is the next immediate appropriate step in this case? So what is this case? You can see bronchovascular markings are seen in this lung, and this lung is having pneumothorax. So pneumothorax, very clear picture. There is no bronchovascular markings, only air is seen. So this is a case of tension pneumothorax. I'm feeling this is because patient is having low BP, respiratory rate increase, pulse rate increase. So we can think this case as a tension pneumothorax. What you should do next? So this question, all of you have prepared only as one content. I'm going to discuss it, needle insertion. So this concept is again another interesting concept for your exams. Injury to the chest. Thoracic injury. Definite question will come for you in this exam. In a thoracic injury for a patient, in a patient who is having a thoracic injury, first I will do as usual A, B, C, D, E. Okay, as usual I will do A, B, C, D, E, airway, breathing, circulation, disability. And now if a patient is in a breathing comes this pneumothorax. In a pneumothorax evaluation, breathing comes as tension pneumothorax. It is a red emergency. Red emergency. There will be absent breath sounds, low BP, raised JVP, everything will be there. So what should be done next? What will be the best? There are two questions in this. So what should be done next? 28th edition Bailey cleared the long run controversy. That is 28th edition Bailey has given. Next to be done is needle thoracocentesis. You have to put a wide bore needle. We have to put a wide bore needle. About 16 gauge needle will be put in which place. Now it is very clear. Mid axillary line in the 5th intercostal space is correct. So this is the latest answer. So mid axillary line in the 5th intercostal space is the latest answer for your exams. Now answer is very clear now. Needle intercostal space, 5th intercostal space, that is needle is inserted is the next best step. So what is the best step? Next step is needle. So this controversy is very clear. In children, it is 2nd intercostal space, mid clavicular line. In adults, 5th intercostal space, mid axillary line. This is no more confusion. Okay, this is no more confusion, and it is a clear-cut concept. Never worry about it. But this is, please remember, it's a first aid. Actually, it is like a first aid. We have put a needle. Just patient will have time for putting the best treatment is intercostal drainage tube, which will be put at mid axillary line in the 5th intercostal space. So this is the correct answer for this question. So simple answer for this question is very clear. We have to go for immediate thoracotomy wrong, pericardiocentesis wrong, pleurodesis wrong, chest drain insertion and drainage, underwater drainage. So most of you are correct. Very good. Vishnupriya, Priyanka, Vijay, all of you are correct. This is a clear-cut question on chest drain and insertion. So please don't forget, this is a high-yield question. Definitely, there is a chances of getting a question from pneumothorax. Definite chances of getting a question from pneumothorax. You should never have a doubt in this. So I have explained it. I will be sharing these PDFs in my channel on Telegram channel on Surgery Sixer. You can download the PDFs also. Okay, you can download the PDFs with the explanation. Answers will be there. So coming to another important question, which you know very well, which is being again another favorite question of National Board exams is primary and secondary survey. Which of the following is not included in primary survey of a trauma patient? See, very basic question from trauma. So definitely there is going to be some 3 or 4 questions in NEET PG from trauma. So you should be thorough with trauma. Any doubts you have in trauma, please post it. This is advantage of attending live because this lecture will be available in the YouTube afterwards also. But if you are going to attend it live, you can ask doubts, you can get clarified all your confusions. So which is not included in primary survey. I told you primary survey is A, B, C, D, E. Airway, breathing, circulation, disability, exposure. So in this, which is not coming. So exposure includes log roll. Please don't forget. Log roll comes under exposure. So which is done by 4 people for examining the spine. Log roll comes under exposure. Recording BP is a part of circulation. Exposure of whole body is there. Airway, breathing. CT is a part of secondary survey. Please don't forget, all investigations will come under secondary survey. Okay, this is now the next important protocol. Trauma is full of protocols. If you see, trauma protocol is very clear. When a patient with trauma comes to you, what is the protocol order? That is the question they always ask. The first thing you should do is A, B, C, D, E. In the airway, it includes one of the important things, that is cervical spine stabilization. So as a part of airway, cervical spine stabilization is also included, in which we will do jaw thrust, chin lift and udal airway, because to prevent tongue falling backward, because most of the time the tongue falls backward and will cause the obstruction. So I have to do jaw thrust, chin lift and udal airway should be done for the cases. So this is first step, airway, then breathing, circulation, disability, exposure, everything will be going on. And the secondary survey, this all comes under primary survey. Secondary survey includes, we have to ask the history, detailed history from the patients, which includes ample. This is ample is a mnemonic for secondary survey. Allergy history, ask history of allergy from the patient, history of medicines in the patient, past history of any drugs or anything like pregnancy, everything you should ask. Last meal, okay, last meal we should ask. So, and explain the injury, ask him to explain how the injury happened. Explain the mechanism of injury. So allergy history, medicine history, past history, last meal, because we have to plan for surgery based on last meal. Explain the surgery. All are done in secondary survey. All are done in secondary survey. And after all these things, we have to take X-ray of cervical spine. X-ray of cervical spine will be taken based on nexus criteria. Based on nexus criteria. And whole body CT scan will be taken for injury severity score more than 36. So when the injury severity score is more than 36, we will take whole body CT scan, and X-ray cervical spine will be taken based on nexus. N for neurological deficit, E for extreme mechanism, ethanol consumption, E for ethanol history of consumption, X for extreme mechanism of injury, U for unable to recall, means LOC, and S for spine fracture or tenderness. So these are the nexus. Neurological deficit is present, ethanol history present, extreme mechanism of injury, and unable to recall spine tenderness. All this will come under secondary survey. So all are secondary surveys. Like any investigation you're going to do will be secondary survey, except log roll. Please remember, log roll is a part of exposure primary survey. This is again another FMG as well as NEET PG question. Log roll is a part of primary survey. Okay. So simple question. See how easy the questions when you are now reading after preparing the subject. Okay. Most of you have answered very good. Very good. Vishnu Priya, Femi, Selva, Vijay, everyone has answered it correctly. So the third sensational question, you're all absolutely correct. So this is the third sensational question for the exam. The fourth question you all know very well. There will be no single paper either in NEET PG or INI set without a question on GCS. So what is the Glasgow Coma scale of a patient presenting after injury? Confused, eye opening for painful, withdrawal flexion on left side, localizing to pain on right side. So let me explain you this GCS, high yield MCQ for your exam. GCS will be definitely the fourth important concept I want you to know is on GCS. So eye opening, verbal, motor. These are the three things we are going to take up. Eye opening, spontaneously opening eyes, we give them 4 points. On commands, he is opening the eyes 3 points. On pain stimulus, he is opening is 2 points. So your case is having a point of 2, pain stimulus, because he is opening the eyes on pain stimulus. And not at all opening is 1. So the answer for your question is pain. The patient is opening the eyes on pain stimulus. So verbal now, verbal. So I used to tell the simple mnemonic. Yes, it will be available always. It will be available in my YouTube channel. Don't worry. One confused word sounds nowhere. Just 2 more questions. Don't worry. One confused word sounds nowhere. I don't want to waste all of your time during the last minute of preparation. Just keep these live sessions during your dinner time. I will be taking the class only between 8 to 10 for 1 hour or 45 minutes, maximum 45 minutes to 1 hour. So you can plan your dinner and keep the YouTube on the side and you see these videos. Definitely, I'm going to cover you all the essential topics in NEET PG. Okay. One, confused means oriented. Patient who is oriented will be 5. Confused will be 4. Inappropriate words 3. Incomprehensible sounds 2. No sounds 1. So one confused word sounds nowhere. One confused word sounds nowhere is a mnemonic. 1 is for oriented. Confused is patient is confused. 4. Inappropriate word sounds nowhere is 1 point. This question patient is using inappropriate words is given in the choice. Okay, you can see patient is having confused. Okay, the confused is given in the choice. So the confused gives 4 points. The confused question goes for 4 points, pain 2 points. Motor response is highly expected. When this question came at that time, Bailey was very clear about the motor response in 2020. They are mentioning this point. Obey. This is a mnemonic I have prepared. Obey localites with flexion extension now. With flexion extension now. This is a mnemonic. See how simple mnemonic. Obey localites with flexion and extension now. Obeys commands 6 points. Localizes pain 5 points. Withdrawal 4 points. Flexion deformity is D. Corticate rigidity. Extension is D. Cerebrate rigidity. 3. to 1.65432 is the answer for this question. So in your question, the answer is asking about two different limbs. Motor response, you can get two different limb. Right limb one value, left limb one value can happen. So let us see what is there in the question of this. Withdrawal fluxion on the left side. So withdrawal fluxion, obey localites with obey localites with means 654 points and localizes pain on the right side. Obey localizes pain on right side is 5 points. Which are you going to take now? So painful stimulus opening, I already told you the points are how much? It is 2 points. Confused patient had a one confused word sounds nowhere. So confused patient had a score of 4 points. Okay. Now, which will you take in motor? Fluxion, withdrawal fluxion, 4 points. Localizing pain on right side is 5 points. Take the biggest score is the answer for this. Okay. So the score is 11. So the score is E2, V4, M5, 11. So my extreme warning, never enter the exam hall without memorizing GCS. Without memorizing GCS, never ever enter into exam hall. Definitely this question is going to come for you. One of the question will be coming for you from this GCS. So I have not seen a single paper without this GCS. And that is why I'm giving you a simple mnemonic. Please remember verbal, one confused word sounds nowhere. Simple, one confused word sounds nowhere. Obey localites with fluxion extension now. Mnemonics, obey localites with fluxion extension now. That's a question of fourth question. So most of you have answered it very good, correctly. So answer is C, 11. The score is 11. Okay. A patient, now sensational question, fifth question, which I have already discussed. Because I'm telling you, this question will definitely repeat. A patient suffered from blunt trauma to the abdomen and was brought to the emergency room. He is unstable. Please remember, he's unstable. BP is 90. You are the doctor. Basic resuscitation is done with intravenous fluids. Fast is positive. He is not improving despite IV fluids. Next step in the management. So I'm telling you, this is FMG question, but the same question has been asked in NEET PG also in multiple ways. There will be no excuse if you are going to make wrong in this question. I'm telling you, there will be no excuse in the exam. You should never ever make any mistake in this exam. Yes, patient is simple, having fast positive, and he is unstable. I have to shift him for exploratory laparotomy. Laparoscopy has no role in trauma. Never ever forget this point. In trauma, laparoscopy will not be done because patient is already sick. We will not do any laparoscopic procedure for patients. So unstable patients in trauma, in abdominal injury, please have no confusion because they will always ask abdominal trauma unstable only. You should directly go for laparotomy if E-fast is positive. E-fast positive, unstable abdominal injury, laparotomy should be done. Laparoscopy is contraindicated. We will not go for laparoscopy. We have to do laparotomy by what incision? We have to put a long midline incision like this. So long midline incision is done. So a long midline incision has to be done. And we have to do for an unstable patient, we have to do damage control surgery. Damage control surgery should be done. In damage control surgery, there are 5 stages. Stage 1, stage 2, stage 3, stage 4, stage 5, because damage control surgery is also a favorite question. In stage 1, identify the patient for damage control surgery. Stage 2, emergency OT, you go open the abdomen and do simple procedures like packing the bleeding, keeping the bowel out in leak, etc. Stage 3 will be ICU management. Stage 4, shift him for elective OT. Stage 5, you have to plan for closure of abdomen. See, that means what? The point I'm telling you here, this question is, in stage 2, I will not close the abdomen. Abdomen is not closed. It will be left open by covered with a Bogota bag. Abdomen not closed in stage 2. We will keep a plastic bag like Bogota bag, off-site dressing, or even VAC is not used here. Don't forget this point. VAC is not for damage control surgery. VAC is for burst abdomen. Many students may get confused. What will I do now? I'm not going to close the abdomen. That means I won't go and keep a VAC. Vacuum is not done now because I am going to reopen him after 48 hours. After 48 hours, I will shift him to theater again. If he's alive in the ICU for 48 hours, I will shift him to theater after 48 hours. Don't forget this. Okay, very important. So this is Bagota bag or a plastic bag only will be closed. That's the answer for this question. Exploratory laparotomy. E-fast positive unstable cases, laparotomy, E-fast positive stable cases, CT abdomen. So the last sensational question for your exams from trauma chapter is, a 30-year-old car driver was involved in an accident. He is brought to emergency room with a complaints of breathlessness. On physical examination, vitals are pulse rate 110 per minute, BP 90/60, temperature of 37 degrees, extensive bruising noted on the chest. An urgent bedside X-ray chest was done, which is what is the case? What is this case? So this is a case of, what is the diagnosis from this case? The case is a flail chest. This is a question on flail chest. Simple question on flail chest. So what should I do? Thoracotomy, thoracostomy, elective intubation and PPV, and fluid resuscitation. Which will be the correct answer in this? Extensive bruising is there. What is the best management is in this case? The image shown here is flail chest. Flail chest is defined in Bailey and Love as fracture of 3 or more ribs in 2 or more places. So traditional treatment was to put the patient on mechanical ventilator and do internal splint of the chest. So this patient is now having multiple fractures. The ideal question should be E. Then what is the best management means? Analgesics plus nasal oxygen. That should be the correct answer. But here, if you see on examination, vitals are pulse rate 110, BP 90/60. So the BP is falling means he might have what? Extensive bruising in the chest means he might have associated one more problem inside. What is it? So the answer is not elective intubation and PPV. That is not the best answer here. Please remember. So the question is, what is the best management now for this patient is, he is having low BP. Pulse rate increase means, what do you think? I'm telling you, this is one of the complications of flail chest. You are all thinking of flail chest. See, in an FMG exam, they have asked a question beyond flail chest. I'll tell you the protocol in the flail chest now. Because if you directly read this question, you all will go for PPV ventilation. That is wrong. Flail chest. It's an injury of ribs. Bailey says 3 or more ribs in 2 or more places. But this is now changed as 2 or more ribs in 2 or more places. It's a new answer. 2 or more ribs in 2 or more places. What happens? The fractured ribs. The fractured ribs like this segment will become a flail segment and it will move paradoxically. Paradoxical respiration happens. This is all of you know this very well known answer. You all should never forget there was an old concept. See, you are all answering an old concept. The old concept is paradoxical respiration. If it is present, it is a clinical diagnosis. No need of even X-ray. Patient used to tell flail chest is a clinical diagnosis. No need of even X-ray. But now, recent update is what in this? All cases of flail chest, all cases, please remember, see the word I'm telling. All cases of flail chest must undergo 3-dimensional CT thorax. If you know the reason for this, you will never ever make the answer wrong. The answer is, I am now least bothered about the fracture of the rib. Please understand, this rib fracture is not going to kill the patient. Even his paradoxical respiration is not going to kill the patient. We are very much worried about the underlying pulmonary contusion. Very important. Underlying, the rib would have gone and porked the chest into the lungs. Pulmonary contusion is going to decide whether this fellow is going to live or not. The underlying hemothorax is going to decide whether he is going to live or die. The underlying, as you're telling, pericardial injury is going to decide whether he is going to live or die. So whatever it is, now in your case, if you see, this guy is having low BP and pulse rate. Low BP, increased pulse rate means he is bleeding somewhere. Probably he is bleeding somewhere. So bleeding is going on for him. Therefore, what should I do next? Answer is, the next thing, what should I do is go for, somewhere it's gone. So as per the question, I should go for a, so as per this question, low BP, increased pulse rate, I should go for fluid resuscitation, nasal oxygen, and fluid resuscitation, nasal oxygen, and painkillers are the first important role in this. First important role. So then we have to take CT scan chest, and then only we can decide on the management of flail chest. So many of you answered to do IPPV. Yes, it was an old concept. I'm telling you, in olden days, what we used to do 10 years back when I'm doing MS post-graduation, whenever we see a flail chest with a paradoxical respiration, immediately we used to do IPPV in those days. That is abandoned now, not needed. They are telling if the PaO2 is falling, if PaO2 is falling less than 60 millimeters mercury, in spite of fluid, nasal oxygen, painkiller, then only you should intubate. Please carry home this point for the last minute of exam. So this is that is why I'm telling, I have kept the test series as sensational 6, because these are sensational questions which you can answer only you have a deep knowledge in this concept. So this is a classical question. The answer in this question will be, ideal answer in this question will be analgesics and nasal oxygen and fluid resuscitation can be accepted. So then only we will plan for a CT scan and everything we have to do, and we have to plan for thoracotomy, thoracostomy, elective intubation. Everything is not the ideal answer. So we have to know certain important facts which are not given in this question. But in this question, I will say what should be best management of this case is fluid resuscitation. I'll go for fluid resuscitation in this case. So please remember this. Currently, the treatment is adequate analgesics, oxygen admission, and physiotherapy. Ventilation is reserved for cases developing respiratory failure despite analgesics and oxygen. So please don't worry about the ditto questions. You have to only learn the concepts. So I'm seeing many questions doing MCQs, means they will always mug up the MCQs. I'm telling you, don't mug up the MCQs. You have to only learn the concepts. The same question will not come back again. The same concept only will come. So it's waste of time reading hundreds of MCQs. You should always utilize your time to read only 6 MCQs I have discussing here, but from the 6 MCQs, I can do 200 MCQs. So therefore, it is no use of discussing 200 MCQs. What you should do is, you should learn the concepts as I am discussing. This is the only way of preparation, okay? Very good, Priyanka. It is for concealed bleeding. That's correct. So a bonus question for you, because it's a very old, famous, familiar repeat question. In E-fast, which of the following needs immediate lapro exploration? So in E-fast, which this is a direct question from FMG, August 2020. E-fast, which of the following zones need emergency lapro exploration is the question. So zone 1 and 2, zone 2 and 3, zone 1 and zone 1 and 3, which is correct answer in this? Anybody? Yes. First of all, this question I will say is absolutely wrong. Can anybody tell why this question is absolutely wrong? Yes. This is the last concept I'm going to discuss for today. First of all, you should understand this concept is this. You each question you're preparing. No, I will always tell 3 facts you should take. Each question, ask 3 questions among yourself. Question number 1, you should know whether you know the concept. Yes, very good. Excellent, Selvananda. That is correct. 1 only. Yes. C. Vishnu, Priya, everyone is correct. So question number 1, you should know whether you could understand what concept is this. Yes, I could find out what is this concept. Then you can go for ask the second question. Question number 2, have you read the concept so far in your preparation? Yes, I have read the concept. Then question number 3, you read the question now and see the choices. If among the 4 choices, you can identify 2 choice minimum, you should identify, correct or wrong. Then you can answer the question. Otherwise, you should not answer the question. If you have not read the concept, stop here itself. Don't read that question further. If you have read the concept, okay. If you know the concept, but you have not read, no use of further going on. Yes, you have read it and you could exclude two choices, then only you should waste time on this question. Please follow this. Never ever a question will become correct in a fluke manner. In a fluke manner or a inky-pinky way, no question can come correct, especially for a PG aspirant, because PG aspirants are the most unlucky people on the world. So when you are in an unlucky period, nothing will work for you as lucky. Okay. Never ever follow a inky-pinky funky rule or try to answer it by a fluke. Definitely will go negative only. Therefore, if you know the concept, this is a concept on retroperitoneal hematoma. So why I am telling you this question itself is wrong, because the examiner who took this question was not knowing retroperitoneal hematoma could not be identified by E-fast. But itself that examiner who said that paper does not know. So E-fast could not be, is not useful. In fact, not useful for retroperitoneal hematomas. Retroperitoneal hematomas can be diagnosed only on CECT abdomen. Without knowing this basic concept that examiner has made a question on if E-fast is showing 4 zones is absolutely a wrong question. Okay. But anyhow, the concept is correct. There are 3 zones of hematoma. And all of you have answered it very good correctly. It is zone 1 is a zone which is containing aorta and IVC. This is zone 1. Aorta and IVC. This is zone 1. This is bleeding means I have to take it for surgery because it's a major vessel which is bleeding. Aorta or IVC, something is bleeding. I have to take for surgery. If it is an aortic bleeding, what maneuver will I do? Basic question, Metox maneuver. IVC bleeding, what will I do? Kettle maneuver. I hope you know what are these. Metox maneuver is exposing the aorta by rotating all the structures from the left side. Kettle maneuver is exposing the IVC by rotating all the structures from the right side. So that is Metox, MAO for aorta. AO for aorta. Don't get confused in this. Zone 2 is a zone of renal injury. We don't operate always. Renal injury is zone 2. Zone 3 is a pelvic hematoma. We don't operate. We only put a pelvic binder. Zone 3, pelvic binder is enough. So the answer in this question is very clear cut. This is classical answer on zone 1. Okay, aorta and IVC injury. Okay, so any doubts you have, please tell me. That completes the discussion for today. This is all. Like this only, I'm going to do very small, short sessions. That is why I discussed as 8 episodes instead of making as 2 episodes, 1 or 2 episodes. I wanted to distribute it all along. Okay, so that it will be helpful for you for your exams also. So hope you are clear. Any there are 4 maneuvers in the abdomen. As you are asking, there are 4 maneuvers in the abdomen. I can tell. Only thing is, for explaining the maneuvers, I should be exposing my abdomen. So the 4 maneuvers, there are 4 maneuvers in the abdomen, inside the abdomen. Number 1, Metox maneuver. Metox maneuver is, I want to reach the aorta. I will rotate all the structures from the left side to right side. Okay. Left visceral medial rotation is Metox. Left visceral medial rotation is Metox. Right side viscera rotated medially is known as Kettle. Kettle for IVC. Metox for aorta. Pringle, most of you know what is Pringle maneuver. It is an applied anatomy question. Clamping at the level of epibloic foramen is known as Pringle. Clamping at the level of epibloic foramen is Pringle maneuver. And Cocker's maneuver is, you know very well, duodenum is a second, third, fourth part are all retroperitoneum. To bring the second, third part of duodenum intraperitoneally, we mobilize the duodenum known as Cockerization maneuver. So you know very well, Theodore Cocker is the first surgeon to receive the Nobel Prize. He is a father of thyroid surgery. He has done some procedures in the abdomen also. One of such procedure is Cockerization maneuver. So Pringle maneuver, Cockerization maneuver, Metox maneuver, Kettle maneuver. So definitely applied anatomy question will be Pringle maneuver. Metox and Kettle will be part of trauma question. Okay. So thank you all. So I will be announcing soon the session 2. Please follow me on my Telegram channel and Instagram channel. And I will be posting in this YouTube also when the next session is coming on. So because as soon as I get a free time, I will announce it 2-3 days before the sessions. Okay. It will be only just 45 minutes to maximum 1 hour session. So please utilize it. Thank you all for attending the session sincerely. Please share the video with your friends. Let them also get utilized. Thank you all. Thank you so much for attending and being interactive so much. Thank you, Selva. Thank you, TN McQuench. Thank you all. Bye.